Anyway, I want to introduce, for our main presentation today, is Dr. Filomena Trindade, MD and MPH. Filomena is an internationally sought-after speaker in functional medicine. She's a graduate of the Fellowship in Anti-Aging, Regenerative and Functional Medicine, teaches in Florida, a master's program through the University of South Florida, as well as for the Institute for Functional Medicine. And I want to just put my 2 cents in here, that she was one of the teachers for the hormone module, and that I just completed a couple of months ago, a month or 2 ago, and was very, very appreciative of your presentations. After her obtaining her BA degree in biology, she went on to finish a master's in public health in the area of environmental health and epidemiology before starting medical school. She graduated first in her class in family practice from the University of California Davis School of Medicine and did her residency training in family practice at UC San Francisco Santa Rosa program. She has been in clinical practice for over 16 years. Before starting her own private practice in 2004 in functional medicine, she was the medical director of a nonprofit organization that catered to the underserved. She is currently very active in developing teaching programs in functional medicine in the USA, Latin America, and Europe. And this evening, she's going to be speaking on diabesity. And I would like you all to give Dr. Trindade a very warm welcome.
Thank you. I'm going to just say one little comment. I'm going to use my time up here about the shingles vaccine. And that is that it is not a very good vaccine in general. So you want, anytime if you decide you're going to get a vaccine, talk to your doctor and read up on it and see just how effective it is. I won't let my parents get it, just to give you an idea, and I won't take it myself. So diabesity. How many of you know what diabesity is? Cool. So it's diabetes or any diabetes-related condition, because as Dr. Husband said, most things in health or in life in general are on a continuum. So diabetes type 2, especially talking about type 2, it's all about a continuum. It's not so much do you have it or not, but where along the continuum are you? Because you become insulin resistant, and if you progress, you can be impaired glucose tolerant, which means you no longer can keep your fasting blood sugar normal. You can become pre-diabetic or you can become diabetic. So it can be anywhere along the continuum, and not just being overweight or obese, but having an obesity-related condition. And diabesity was coined by Mark Hyman, and it's sort of taken off in a sense. But just to have an idea that that's really what we're talking about. And so my main thing is, how do you diagnose it? And how do you reverse it or stop its progression early? Because what we know is that anybody who's on that continuum, it's not just about can you progress to diabetes, but it's the fact that you can develop conditions related to it just because you're insulin resistant. And so that's what we want to focus on, is on insulin resistance. So why am I talking about this in general? Because in the United States, we tend to have a lot of like we just heard about pre-Hashimoto's, right? And you hear about pre-diabetes. My best friend one time called me up and said she had just been diagnosed with prediabetes. So my next question was, oh, so what's your doctor doing about it? Guess what she said? Nothing, waiting. Waited to see if it progresses. So I almost wanted to jump through the phone line the other end, because I'm like, no, this is where you need to try and figure out what were those triggers, what were those antecedents, and how can we reverse it? Because what is the big deal about being pre? Do you know that a pre-diabetic, well, first of all, let's just talk about diabetes in general. What's the problem with it aside from the diabetes type 2 itself? It's what it can cause, right? It's what it's related to. And it's the fact that diabetics are 4 times more likely to die of a cerebrovascular accident, of a stroke. 3 times more likely than patients that are not diabetics to have a heart attack. What do you think pre-diabetics are at risk for compared to those numbers I just gave you? Exactly the same. So a pre-diabetic is 4 times more likely to die of a stroke and 3 times more likely to die of a heart attack. So to me, the thing has always been, well, How do we diagnose it early? And why do we see such high rates of diabetes? I was always told that it was because of the high rates of obesity, right? And I'm not arguing that fact, because what do we know about the rates of obesity in the United States? They have increased tremendously, right? If you just look at, for example, 1990, we had no state in the union that had obesity rates of 14% or higher. But a mere 20 years later, in 2010, we have no state with rates less than 20%. So huge, huge increases. And I was always told that the reason why we have such high rates of diabetes is because we have such high rates of obesity. But I want you to think that maybe the reverse is true. Maybe the reason why we see such dramatic increases in obesity is because we have undiagnosed insulin resistance. And nobody's really looking at that. So we want to look at are you insulin resistant or not, and how can we make you more insulin sensitive. And even if you look at the CDC, for example, they say only 40% of your risk of developing diabetes occurs in people who are obese. So my thought is, well, what do I do with the other 60% that walk into my office? Now, to bring that point further home, we can look at the National HANES data. Now, let's just look at the three groups that we have on there. And by the way, when they did this study, they were looking at cardiometabolic rates. So they were looking at metabolic syndrome, which you have to have 3 out of 5 criteria, the most important be insulin resistance. And I'll go through that in just a little while. But let's just, for the sake of simplicity, say that those are rates of insulin resistance. Okay? So if you are obese, which means you have a BMI over 30, so those people I always think of, okay, those patients that walk into my office that have a BMI over 30, that are obese, about 2/3 of them are going to be insulin resistant. Even more so, because we know they're going to fulfill rates of the cardiometabolic syndrome, but I'm simplifying and just saying 2/3 of them are going to be insulin resistant. That kind of makes sense. Okay, that's possible because we know that obesity can lead to diabetes, but I just told you that the reverse is also true, right? That insulin resistance can be the cause of obesity. But look at those who are overweight but are not obese. About half of them, right, will be insulin resistant. But look at those who are not overweight. So normal weight people, over 26%, so I say almost 1/3, over 1/4 of them are going to be insulin resistant. And if we're not looking for it, we're not going to find it. So it's extremely important to realize that it's not just in people who are overweight, but it's also in people who are thin. And just to bring home sort of the point about the difference between insulin resistance and metabolic syndrome, because I hear a lot of my colleagues talking about them as if they're the same thing. To have metabolic syndrome, you have to have 3 out of the 5 criteria. And the most important one that's emerging is insulin resistance. So it's extremely important that we diagnose insulin resistance early. So then my next thing is, okay, well, what causes insulin resistance? Because in functional medicine, we try to find the root cause, right? And once we identify it, then we can try and reverse it, or at least stop its progression. So in 2012, I came up with this list, and it's sort of evolving. But this is what I look for. This is my list. It's what I use for when I look at patients or talk to my friends or even my colleagues or when I teach. So things like food sensitivities, which we already talked about, that could have been the trigger that then caused someone to become insulin resistant. And you can have more than one, right? It could be dysbiosis, so changes in the gut microbiota, toxins, hormone imbalances, infections, especially occult ones, and prescription drugs, right? Particularly statins. We now know that statins, which are the cholesterol-lowering drugs, can cause diabetes through a couple different mechanisms, or insulin resistance. And I hear a lot of my patients and even my students and colleagues talk about, oh, it's all genetic. Well, in type 2 diabetes, no. And what do we know about most of the common day or chronic diseases? They're only about 20% genetics, and the other 80% is environmental. And we know that through the work of Dr. Bruce Ames, who's 90, 94, 95, I believe, and still going strong. And then realize that you can have more than one thing going on. Right? I remember my medical school teacher once told me, you know, your pets can have ticks and fleas, right? So that means that we can also have more than one underlying trigger or mediator contributing to a disease. So you have to look for that, the fact that some patients might have more than one. These are just a couple studies showing how food antibodies can actually be that trigger. I didn't just pull those things out of a hat, but there is actually scientific information showing that. And then gluten, a big one. Now, gluten, we have more literature in type 1 diabetes, but the nice thing about the literature, it's actually showing the mechanism. And the way that gluten, for example, can cause type 1 diabetes, because we can extrapolate it to type 2, is that it causes damage to the pancreas. So it's damage to the pancreatic beta cell, the cells in the pancreas that produce insulin that can then cause insulin resistance. So extremely important. And dysbiosis means a change in the gut microbiota. So it's not exactly an infection, so it's not like a foreign bacteria, but it's a change in the normal ratio of bacteria. That could be the cause of diabetes. And then we also know, of course, about our food and the extremely high amounts of sugar, right, that we're eating. And this is an example in fruit juice, but any prepackaged food, if you read the label, it's full of sugar and a lot of other food additives that are not very healthy and that have been shown to actually damage the pancreatic beta cell. And I'll get to that in a little while. And then what about the non-caloric sweeteners? And your high fructose corn syrup. All of those has also been shown to cause damage to the pancreatic beta cell, as well as mitochondrial dysfunction. Now, with mitochondrial dysfunction, I always want to look and say, well, why did that person develop mitochondrial dysfunction? So the mitochondria is the powerhouse of the cell. It's what makes energy, but we know that something triggered it, right? Something caused damage to it. So I always feel like with mitochondrial dysfunction, we need to dig a little deeper and figure out, was it an infection, was it a toxin, was it a food sensitivity, or was it a nutrient deficiency? And then what about toxins? Well, toxins we can classify in different classes, right? But the persistent organic pollutants are a big one. We have lots of literature, and I'll go through some of the other ones as well. So phthalate, where do we use phthalates? Anybody know? Plastic, exactly. Why do we put phthalates in plastic? Soften. It's what makes it malleable. And we've heard a lot in the news about bisphenol A, although we've neglected to hear about the other bisphenols, which I think we're up to at least the letter U in the alphabet. But phthalates are also an important one that haven't really been talked about. So does that mean we get completely rid of plastic? Well, I'm not sure if it's possible to live without plastic these days, but what do? You try to avoid it as much as possible, right? You use glass whenever you can. I freeze in glass. You refrigerate things in glass. And you try to never, ever microwave in plastic or freeze in plastic if you can. Now, what about other persistent organic pollutants? Does anybody know what perfluorooctane is? It's what's used to make things impermeable to water, right? And it's especially in baby strollers and car seats, as well as mattresses. And we know from the Environmental Working Group, who actually did a study on the cord blood of newborn babies, high amounts of perfluorooctane, in addition to many other toxins. So extremely important that we try and limit our exposure as much as we can. Dioxin. Now, why is dioxin so important? Well, it's a persistent organic pollutant, but in our bodies it behaves like a fake hormone, particularly a fake estrogen in women, a fake testosterone in men. So it's extremely important that we try and be aware of dioxins and where we can get it from, but also to test for it, because a lot of these things you can test for them. This is a study from Sept, Italy, where they had the biggest exposure of dioxin in 1976. And what they did is in 1996 they started this study. And they were looking at rates of insulin resistance and diabetes. And what they found was that the areas that were closest to the exposure, so the women that had the highest levels of exposure and were the youngest at the time of the explosion in 1976, had the highest rates of insulin resistance and diabetes. Now, all of these persistent organic pollutants that I've talked to you so far show a high correlation, because you all know in science it's hard to actually show a causation, right? So we can talk about correlation, and we can also talk about and try to identify an actual cause, but correlations are much easier to show than causation. But when it comes to the persistent organic pollutant, the PCBs, we actually can show cause, that high exposures to PCBs cause diabetes. And what about just living in a polluted area? We know that increased amounts of air pollution can be that trigger for insulin resistance, as can heavy metals. Now, how much is too much in terms of arsenic? Anybody know? We actually have a pretty low threshold. So eating a half a cup of white rice a day that's not organic can put you over the EPA limit for arsenic toxicity. So what do? Well, you try and you eat brown rice, or you try to at least limit the amount that you eat, and you get organic whenever possible. And I also say, and try and do the things that help you detoxify and combat that as much as you can. This is a study on mercury. So exposures to mercury or increased amounts of mercury being that trigger that then caused you to develop insulin resistance. Statins I already mentioned. One way they do it is actually through an immune mechanism, and the other is because they lower you can think of it as a hormone in our body called adiponectin, which actually causes insulin sensitivity. It actually protects us from developing insulin resistance. Now let's just take a little bit of a step back now and look specifically at the gut microbiota and how does changes in the gut microbiota then cause insulin resistance and diabetes. Because for a long time we had lots of studies showing that there was a correlation with changes in the gut microbiota, so changes in the normal flora in our gut, then being the cause of insulin resistance. But the mechanism wasn't really well sort of described. And so for a long time I was kind of scratching my head and trying to figure out, well, how does this work? How does it do it? And how can I then turn around and use this information to help my patients? So I was really happy when this study came out. So this is from March, actually, 2015. It's a very, very conservative European group that did this study. And that I need to say that because the conclusions that they came through were pretty significant, especially for such a conservative group. And so what they were looking at all the major studies that were done, and they were trying to find out what's the mechanism. How is it that changes in the gut microbiota can then lead to diabetes? And they basically broke it down to three main ones that were well studied. There's others, but these are the ones that had the most information. And that is, number one, is by what's called a lipopolysaccharide. So lipopolysaccharide is in the cell membrane of gram-negative bacteria. And they're constantly dying. And so this lipopolysaccharide is being released. And I'm simplifying this. But normally our body's able to handle that. But when you have someone with a very high fat, unhealthy fat diet, then our body's not able to break down the lipopolysaccharides. And that can then bind to this receptor called toll-like receptor 4 and then cause inflammation. So that's one way it can do it. The other is by the fact that when we eat fibers, the gut microbiota breaks those down, uses some of them for fuel. When you have a very low fiber diet, then you can actually create more inflammation and insulin resistance. That's the second way. The third way is by bile acids. So our gut microbiota normally break down our bile into secondary bile acids. When you have an unhealthy gut microbiota, you're not able to do that, and that can then lead to diabetes. Now, the most amazing thing about this study is that these people never mentioned functional medicine. I'm not even sure that they're aware that functional medicine exists, but they had a very functional approach, and they discussed it in the study. And that is that when you look at the gut microbiota, you have to look at all these different factors that affect it, such as how was somebody born? Were they vaginally born? Were they born through a C-section? What medications have they taken all their life? Are they physically active? Do they have a lot of unhealthy habits? Do they smoke? Do they drink a lot of alcohol? And then what do they sort of do in their life? How active are they? So they were really looking at things from a functional medicine perspective without talking about it. And for such a conservative group, it was pretty amazing, to the point that they actually concluded that we should consider taking a microencapsulated pill with a healthy gut microbiota. So then my next question, and sort of trying to put all this together, was, well, then where does insulin resistance start? And what can we do to change that, right? To change that continuum that we find ourselves or our patients in. Because I was taught in medical school and residency that insulin resistance started in the fat cell, which takes us back to what I said in the beginning about the main cause of diabetes being obesity. And that's sort of what we were taught. But it doesn't make sense, because you can have a thin person who doesn't have increased body fat be insulin resistant. And we're seeing that more and more. We're seeing it a lot more, especially in women who have polycystic ovarian syndrome, who tend to be thin and not overweight, and don't have increased visceral fat, because you can have the thin fat person, right? You can have somebody who looks thin on the outside but has fat deposit on the inside. But when you do body composition analysis, you can figure out that they actually are not the thin fat person and can still be insulin resistant. So that made me look for other theories, things that would sort of tie everything that I was learning into place and would help me understand, well, what do we do? So I came across the work of Barbara Corky, pretty amazing researcher. And she's a woman, to top it off. So in 2011, she won the Banting Lecture of the Award, or Award of the Year. That's a sort of the highest honor given by the American Diabetes Association to someone who's made a lot of contributions to the field of diabetes. And she said that insulin resistance begins in the pancreatic beta cell. So it doesn't begin in the fat cell, but it begins in the pancreatic beta cell, basically with damage to the pancreatic beta cell that causes hyperinsulinemia, so too much insulin being produced that then leads to insulin resistance. But that the initial problem is damage to the pancreatic beta cell. She's gone on, she's done lots of publications. Now initially, she was looking at several things that could cause damage to the pancreatic beta cell. And namely, this was like things like monooleoglycerol, which is a food additive, and high amounts of iron and saccharin. But then she went on, and in 2014, she published the article that I have cited here, where she looked at all the possible things that could cause damage to the pancreatic beta cell. And all the things I just talked to you about, the toxins, infections, all of those are covered there and then some. So she talks about the fact that many of the food additives that are added to our prepackaged food are toxins to the pancreatic beta cell, and that's one of the reasons why we see such high rates of insulin resistance in diabetes. Pretty amazing work. So then, what do we do with all this information? How do we put it together? How do we help each other? And for me, how do I help my patients and all the docs that I talk to and I get privileged to try and teach, actually, how to put this together? I think we have to start with a history and taking a full history, right, as providers. And a lot of times we do this as friends, for each other. In functional medicine, you already heard how we look for the antecedents, triggers, and mediators, right? We want to know, how are they sleeping? What's their genetic predisposition? What toxins have you been exposed to? Could you have had a toxin exposure earlier on in your life, like mercury, for example, that then led to your insulin resistance? Just 2 days ago, I had a new patient come to me who he actually comes in for fatigue and numbness and tingling on his feet. And he's had a complete neurological workup. He's seen 3 neurologists, and they basically said, there's nothing wrong with you, right? Instead of saying, well, we can't find anything, but you have something, we just can't identify it. No, your tests are normal, there's nothing wrong with you. But he feels horrible, and it's affecting his daily life. And my first thought was, you're most likely insulin resistant. But he didn't bring with him any prior labs. And he says, oh, by the way, one of my doctors did say that one of my tests was abnormal. And I said, well, then let's look and see, because I'm pretty sure it's going to turn out that you are insulin resistant. This is my clinical evaluation. We're going to get labs to confirm it, but let's try and find the underlying root cause. So I went all the way back to his childhood history, and I said, so what are your hobbies? What do you like to do? What kind of environment did you grow up in? He says, well, I grew up in LA, and I was, in a nice area, not a lot of exposures. And I said, well, what did you do for fun? He goes, well, I used to fish until about 2 years ago, at which time I was too fatigued and I couldn't fish anymore. And I said, oh, did you by any chance make your own weights? He goes, yeah, I used to boil the mercury all the time and watch it bubble. So I'm doing a test to confirm, and he happens to have 8 amalgams in his mouth. So sometimes it takes being a little bit of a detective, but when you say these things to patients, they start to figure out for themselves. Because like you, everybody is sort of their own best doctor in a way. We have to be at this day and age, I feel like. So it's important that you gather all the information and try and put it together. Because we know, for example, that it's all those antecedents that can then cause you to be insulin resistant and then lead to you being on that continuum, which I'll get to a little bit more. So the history becomes really important, and in particular, early history. Like, were you vaginally born? Because what do we know when you're born vaginally? What's so important that you get through the vaginal canal? You get all the good microbes. they're supposed to invade basically your sterile gut, right, as you're being born, and that becomes your microbiome. Now think about those kids that are born in a hospital room, or I should say in the operating room, for example. What bugs are going to get colonize their gut? All the unhealthy bugs, the actual pathogens that have populated that room. So it's important that we ask all those and that we find out too, for example, were you breastfed? Were you bottle fed? And how many courses of antibiotics have you had throughout your life? And when did you start getting those? Because we know that it's the first 15 months of life where you really colonize your gut. And so if you're not getting those healthy gut bugs during that time, then we want to try and introduce them as much as possible. And actually what's being done now, because we have a high amount of babies being born through C-section, right? Very high C-section rates. And so what they're starting to do is if a baby's born through a C-section, they actually gather some of the vaginal fluid from the mom, and you want to rub it on their face and around their mouth. Because that's what happens when you go through the vaginal canal. Because we know that the gut microbiome is really susceptible. This is a study showing that after a 7-day course of an antibiotic, which was clindamycin, without that person taking any probiotics, 2 years later, their gut microbiota still hasn't recovered. So does that mean we don't use antibiotics at all? Well, sometimes they're important. We use them carefully, right, and judiciously, because we also have to take into account that our some of our biggest exposures to antibiotics are not necessarily through the ones that your doctor prescribes. I think we're getting a little bit better, even my traditional colleagues at that. But it's the ones in milk, meat, different types of meat, right? Chicken, it's in our beef, it's in our chicken. So there's a high amount of antibiotics being given to our poultry and our beef and fortune source. So you want to try and eat organic as much as possible. And when you do have to take antibiotics, what do? You know, I travel quite a bit and I caught a parasite. And it was one that I couldn't get rid of with just herbals. And I tried. So I ended up having to take a pharmaceutical prescription. But I take my probiotics along with it. And what I hear from a lot of my colleagues is, oh, you should take them after you finish the antibiotic. What do you think? Is that right? No, you take it at the same time. Not at the exact same time, in the sense you want at least a 2-hour window, because if you take your probiotic with your antibiotic, most likely the antibiotic will kill it. But if you wait 2 hours, then you're fine. And you also want to eat foods that have high amounts of probiotics in it, right? Your fermented foods. And I'll talk in just a little bit more about which type. And then we also want to look at, well, what other things run in your family? Like, is there high rates of cancer or of peripheral vascular disease or depression? Because that tends to show that most likely you have a methylation defect, which means you can't take the B vitamins and activate them. And that in itself can also increase your risk for diabetes and insulin resistance. And then, as I always say, my patients usually come to me with a laundry list of prior diagnoses. It's important that we look at those and see, are any of those associated with insulin resistance? For example, anybody who's had cancer is insulin resistant, and it needs to be treated. In most cases, it's missed. Anybody with obstructive sleep apnea, they're insulin resistant. Probably one of the reasons why they're inflamed. And you want to make sure that that gets addressed, because in most cases it doesn't. This is just a study showing how there's a high correlation with you having sleep apnea and really having insulin resistance that was never diagnosed. And then you want to ask about your digestive function, because that gives us an idea, sort of a window to look through about what is happening with your gut microbiome. Is there reflux, for example? Is there flatulence? Do you pass a lot of gas in between meals? Is it worse with certain foods? Is there food particles in your stool? Do you have constipation or diarrhea? Is there food particles in your stool, which means you're not digesting well, you're not breaking down your food? And what's the number one cause of not breaking down your food properly? Not chewing properly. So how many times do we need to chew before we swallow? 30, at least 30 times. Do you know how difficult it is as Americans for us to do that? But it's extremely important that we start there. I mean, aside from thinking about the foods that we're putting in our mouth, are we chewing properly? And then you have to look at, is there problems with malocclusion with your teeth? But just the act of chewing itself. So it's important that we try and put all this together. And then for years I was told that we needed to rely on a lab value, on laboratory values to see if someone is diabetic or not, or is insulin resistant. The truth is there's many things you can find on physical exam. I just wasn't taught them initially. For example, am I going this? There we go. Just your body shape. Is somebody more gynoid? Do they look like a pear versus they look like an apple? Do they have skin tags? High association with insulin resistance. And what about acanthosis nigricans? That's that dark coloring around the neck. You see it particularly more in people who are more dark-skinned. Very, very big amount of information, particularly on Latinos, and having a darkness around their neck being associated with insulin resistance. But it's not just the neck, it's any intertiginous area. So under your arms, your axilla, your inguinal area. And what about hair loss, particularly in women, but also in men, depending on which pattern you have, or too much hair in women, that can be associated with insulin resistance, as well as just looking at abdominal circumference. How wide is your abdomen? And then looking at nails. Nails tell a story about what's happened in somebody's physiology. So if you have white spots in your nails, for example, anybody know what that means? I know that's a tough question. Low zinc, exactly. What about ridges? Having longitude, like deeper ridges, can be a sign of low HCl, low stomach acid. And we hear so much about too much stomach acid, but we don't often hear about low stomach acid. And there's a whole textbooks written on just nail diagnosis, and we can't remember it all, but you can always look things up. So if you see something abnormal or different in your nails, there's good old Google or the internet that you can look up. Oh, and one thing on there that I forgot to mention is about muscle bulk. So for example, I have patients that come in, and particularly women, and they're exercising 3 to 5 times a week, but when you look at them, they don't have a lot of muscle bulk. And when you question them further and say, are you lifting weights? And they say yes, what does that mean?
Poor healing.
Poor healing, and usually very adrenally stressed. So high adrenaline, right? They're high adrenaline, high cortisol. They're the multitaskers, overdoers, constantly busy. And so they're basically aging by the minute, right? They're very catabolic. They're breaking things down faster than our body can rebuild. So even something that simple can give you an idea as to whether someone may or may not be insulin resistant. And then we know that the android body type is more likely to have low adiponectin levels and high insulin levels in general. And so that you're sort of the typical person you think of with high insulin is the overweight. But remember that I told you that up to 26% of patients with normal weight can be insulin resistant. So I think that's where body composition becomes extremely important. And some docs do it, but actually a lot of gyms are starting to do that, where you look at the percent body fat and your lean muscle mass to give you an idea if you have a high amount of fat, even though you may be normal weight. And what about high cortisol? How do you see someone with high cortisol? These are all my patients that come in and say, Doc, I used to be flat, never had a tummy, and now I feel like I'm wearing a tire. Those are especially the women in the perimenopausal ages or even before that are burning their hormones and are converting their progesterone to cortisol. So extremely important, that you ask also, has your body shape changed? Or when you see a friend and you notice that their body shape has changed, you want to say, hey, you might be insulin resistant. You may want to look at that. And then high adrenaline. These are most of my patients who are high adrenaline are my athletes who tend to think that they're very healthy, and in most of the cases they're not, because they're asking their bodies to do a lot more than they're able to, or they're not supplementing sufficiently. Because it's not that you can't be an athlete, it's you have to also sort of put back, replenish. And then you gynoid body type. So what did I always learn in medical school? That was protective, right? That if you are sort of the hourglass figure, you're protected for heart disease. But actually we know that's not necessarily true, and that you're more at risk for your hypothalamic, pituitary, adrenal, and thyroid dysfunction, as well as some of the detoxification abnormalities, and also more gut issues. So it doesn't necessarily mean that you're protected from one thing and from another, but even with heart disease, we know that the extreme gynoid can have as high risk as a woman who's more android. And then I was trying to show here a high estrogen body type, which is your extreme pair. because those women are even more at risk for developing insulin resistance and diabetes, and I'm going to show you how. Because when you're insulin resistant, you tend to increase your 1720 lyase activity. So think of it, you're increasing an enzyme that leads to your body making more testosterone. But in addition, you also, being insulin resistant, causes the liver to make less of another hormone called sex hormone binding globulin, which actually is a carrier for some of the hormones, particularly testosterone and estrogen, that then leads you to to have higher amounts of testosterone and estrogen. So just being sort of your extreme gynoid is a risk factor for having diabetes. Now remember that continuum that I talked to you about? If you remember nothing else from what I say today, I hope you can remember this. That the important thing about insulin resistance is where on that continuum you are, identifying it early and trying to reverse it. And that is, if you're completely insulin sensitive, so let's say you're well and you're insulin sensitive, you can slowly start to develop insulin resistance, and you may just stop there. So you may be insulin resistant and never progress to prediabetes or diabetes, but you still suffer the consequences, almost as bad as if you were diabetic. So it's all about the insulin. It's all about being insulin resistant, which means your body makes too much insulin, but it doesn't work. The pancreas doesn't know that it keeps trying to make more insulin, and that's what really gives you all the unwanted side effects, so to speak. Because if you're on the continuum, so let's go back. If you're on this continuum, where do you think you start to see all of the changes that we think of with diabetes? For example, retinopathy, right? Neuropathy, problems with the kidneys. Do you think it's only when you're impaired glucose tolerant or when you're pre-diabetic? No, it's actually, you see them all the same. So no matter where you are on that continuum, you're going to see the manifestations, whether you're insulin resistant or you're impaired glucose tolerant or you're pre-diabetic. So what does impaired glucose tolerance mean? That means that the pancreas can no longer make enough insulin to keep your fasting blood sugar normal. Right? So you can have an elevated blood sugar, and a normal blood sugar should be 85. 75 to 85 is your best place to be at. Your risk starts at 81, but the highest risk for heart disease goes up at 85. So a significant difference between 81 and 85, although we know that the lowest that you are between 70 to 81 the best. So we know that if you have an elevated fasting sugar, then you're impaired glucose tolerant, but you may not have progressed to prediabetes and diabetes. And what we're seeing more and more is people who don't progress, who are insulin resistant and stay insulin resistant. And why is that significant? Well, if you're waiting for your blood sugar to be abnormal, you can be insulin resistant and have a fasting blood sugar of 75 and still be insulin resistant. So you have to look at insulin levels. And I'll get more to that in just a little while. So exactly, how do I identify risk? And what labs are we going to do? Because I just told you that you can have a totally normal fasting blood sugar being 75 and still be insulin resistant. So if your doctor's only looking at your fasting blood sugar, we're kind of missing the boat. So these are the things I suggest that we look at. Adiponectin, which is a marker that tends to decrease before insulin increases. So it's an earlier marker. And we know that high amounts of adiponectin are actually protective. Now, when this marker came out, and I waited for it to come out because I was having to prove, or I needed a method sort of, or a way to prove to my colleagues that I wasn't being too strict with my patients in terms of diagnosing insulin resistance. So I was really excited when this marker came out. But now, a few years later, actually 5 years after it came out, we realized that genetically some people can have higher adiponectin levels and still be insulin resistant. So it's important that we also look at other markers. Proinsulin is what you see when the pancreas is working so hard to kick out the insulin that it kicks it out a little prematurely. And there's a guy out of Germany, Dr. Futzner, who has studied proinsulin. He's devoted his life to studying it. And he says that by noticing changes in the proinsulin and monitoring it, you can actually stage where you are in terms of pancreatic beta cell function. So lots and lots of research being done on proinsulin. And I find that a lot of my colleagues aren't even ordering it. Hemoglobin A1C. Well, I was around when hemoglobin A1C first came out. And the reason we developed it in public health was to try and see if patients were compliant. Diabetic patients were compliant with their meds. And so we were aiming for hemoglobin A1C of 7. But what should we really get? We want it as low as possible because we know the small changes in hemoglobin A1C are very significant. Because what is hemoglobin A1C measuring? It's measuring the amount of sugar that has competed with oxygen to bind to the hemoglobin ring. So if you have changes, small changes in hemoglobin A1C, what does that mean? I just told you that it is measuring the amount of sugar that's bound where oxygen should be bound. So it's basically kicked out oxygen and has bound there. You're hypoxic and you're having high amounts of sugar, right? So you can be total insulin resistant, not have progressed, but have a hemoglobin A1C that's slightly elevated. And what is normal? To me, normal is 5.3 or less. As I said, 5. 5 is great. But unfortunately, a lot of labs have not changed their ranges. So they're still using 5.5, 6, and there's literature to show that if you're 6, you're diabetic. So sometimes you have to be smarter than your doctor, and you may need to point that out. So you have to look at your own labs and say, no, this is not normal, and I was going to say argue with them, but sometimes it's not worth arguing. You go find someone else, right, who knows a little bit more. And then you also want to do fasting insulin, but you want to do a postprandial insulin. And I believe in doing it not just an hour after you eat, but 30 minutes. So what you're doing there is you're challenging. You're eating a high sugar load, basically, and I believe eating it with some protein and some good fat so you don't get sick afterwards. And then you want to see how does your pancreas respond. And most doctors will do it just 1 hour, but we have literature to show that half an hour is important to do because some of us are what we call early secretors. That means that you increase your insulin right after you eat that load, not an hour later. So I suggest doing a half hour, an hour, and you can do your 2 hour, and looking at insulin and glucose as well. And then how many of you have heard about nuclear magnetic resonance lipoprotein profiles, or just lipoprotein profiles? Anybody talked about it? So we know that in terms of cardiovascular risk, what's the most important marker you can look at? Is it your LDL cholesterol? No. It's your lipid particle number. It's what is the cholesterol carried in. And so what the literature has shown us, now in my clinical experience, this is not as significant as what the literature says, but what it does say is that in some people, you may see changes in the lipoprotein before you see changes in the insulin. Clinically, I haven't seen that, but the literature is there, that there are some patients where you'll see changes in their lipids before you actually see the insulin go up. So what that means is, if you do your lipoprotein profile and it's abnormal, consider that you might also be insulin resistant. And then things is just looking at your comprehensive metabolic panel, right? These are the tests that most doctors run at least once a year, and seeing if you see any small changes. We always, in functional medicine, talk about looking at labs with functional eyes. So not just looking at the reference ranges, because those are just that. Reference ranges that were developed to detect what? To detect disease. Do we want to wait until we have a disease? No, we want to diagnose it earlier. So we want to diagnose when there is a dysfunction. So you may be looking at sort of your traditional risk factors, but with a different eyes. You want to aim for sort of perfect ranges, not reference ranges. And then things like looking at your GGTP, which is a little bit of what I call a poor person's measure of glutathione in your body, which is the most potent antioxidant. And then uric acid, so smaller changes in uric acid levels, like if you follow your uric acid level and it's going up, that can mean that you're becoming insulin resistant. And then to look at your gut microbiota, you can do a comprehensive stool test, and you can also do methane and hydrogen breath tests, which give you an idea of what's going on there. This is a study just to show that your hemoglobin A1C, even small changes in it, like this was 5.5 or more, are highly associated with insulin resistance, also with heart disease. And this is another one about the insulin at 30 minutes, which is actually from the work of Dr. David Ludwig at Harvard. And then your comprehensive stool analysis can give you a lot of information, not just about changes in your gut microbiota, but about function, or how well are you digesting, how well is your pancreas working, for example, or your gallbladder. So you can get a lot of information there. And then how many of you know your vitamin D level? A few. Good. So very important to look at your 25-hydroxy vitamin D, because low vitamin D levels have been associated with insulin resistance. And then looking at things like your homocysteine, your lipoprotein A, and your CRP, high sensitivity CRP, which is a marker of inflammation. But it's also really important also to ask your doctor, if they haven't done already, to make sure you're not a celiac, because you can have insulin, you can have a gluten sensitivity, but there's also, you can have it all the way up to the point where you can have celiac disease, right? And I've diagnosed a few, actually. Not just those who were diabetic, but in general. Oh, resistant, by the way, is a marker that there's been a lot of literature on that may be a good indicator of insulin resistance, but it hasn't been, it's still sort of in the research phase. I haven't applied it clinically because we don't have that much information. So now let's go on to treatment. So how can we put all this together and develop a treatment plan that maybe doesn't include a lot of pharmaceutical drugs? Because what do we know about pharmaceutical drugs? They tend to have quite a few side effects. And it doesn't mean that we don't use them, but we use them judiciously. And I consider it sort of my fourth line. I always have like a 2 or 3 or 4-tiered approach to just about any dysfunction you can think of. So the most important part, I believe, is removing your antecedents and your triggers, and then trying to modify the mediators as much as possible. And the biggest trigger in the United States is what? Our diet. Yeah, I was lecturing in Europe, and the guy that lectured before me, he goes, that's it. You know how America's always changing things, they're always innovative, and they're always the first to come out with stuff. Well, now they no longer have the SAD diet. And I hadn't been in the U.S. for a while, so I was like, what is he talking about? So he said, it's official. It's now the HAD diet, the horrible American diet. And it's true, right? I mean, we eat food that has, high glycemic load, very low amounts of potassium, high amounts of sodium, low magnesium, right? And then what do we do on top of all that? It's saturated fat. It has a lot of food additives, right? And then we expect to survive. I'm a Costco shopper, and it never ceases to amaze me what other people put in their baskets, their shopping carts. And I'm like, I know what health problems I deal with. How are you still alive eating like that? It just makes me realize what an amazing machine we have, right? How much our bodies can actually take, because in this country they take a lot of abuse. And the sad part is that the rest of the world is following along. We have the highest rates of diabetes, but Europe is following close behind. And when you look at other countries, they're right down the pack, unfortunately. So we want to especially look at the amount of fiber. Now, I recommend eating 35 grams of fiber a day. And my next thing is, well, how do you do that? So I say 2 tablespoons of flaxseed meal. Extremely important for detoxification, for fiber in general, for having your gut microbiome. 1 to 2 tablespoons of chia seeds, 1 to 2 tablespoons of coconut flour, because it's very high in fiber. You can even put it on your salads. You can make pancakes with it. Lots of things you can do with it. And I don't necessarily count all of the vegetables, but that's high in fiber too, because I have my patients eat 12 servings of vegetables and fruit, and only 2 of fruit per day. And for fruit, you want to do your low glycemic load, so all your berries. Your raspberries, your strawberries, blueberries, blackberries, and kiwi, because those are the highest glycemic load. And I want to make sure that we're eating fruit with your meals. Now, I know that some people don't believe that. There's a lot of food combining theories, but when it comes to insulin resistance, if you're going to eat some fruit, and I do believe that we need to do that, because we have studies, particularly from Europe, showing that the benefits of fruit far outweigh the sugar or the fructose effects, because you get a lot of antioxidants. But I think it's important that you do it with a meal that's, where you have your protein, your healthy fats, and your fiber. And then we have to try and avoid the supersize revolution, right? Which, when you look at portion sizes, when you go to a restaurant in the U.S., versus in Europe, for example, there's a big difference. But, we still have the big gulp around, right? And I still see people drinking large amounts of soda, which is loaded with sugar, not to mention all the other unhealthy additives. And then, do you think the food we put in our mouth can affect our gut microbiota? It's not really fair because I just put up a slide. But do you know that for years it was argued and we were taught that no, you were basically, that's what you had and there's nothing you could do about it. And now we know that our high fat, high unhealthy fat, because fat's important, but it's high unhealthy fat. And when I say unhealthy, I'm not just talking about trans fat, I'm talking about hydrogenated fat, which we haven't heard very much about. And it's still there in prepackaged food, and it's just as bad as your trans fat. But so that can change your gut microbiota. So if that means that that can change it and cause problems and increase the lipopolysaccharide amounts, then it means that we can also, by changing our diet, we can change our gut microbiota, right? Which is the truth. But for many years, we didn't think that that was the case. And then you want to avoid all of your non-caloric sweeteners, like saccharin and aspartame and Splenda. Actually, the only non-caloric sweetener that I allow is stevia. And we know that stevia can have an aftertaste, but if you use mostly the leaves and not the whole plant, it has less of an aftertaste. Or you use honey or raw sugar, but very small amounts. Because there's an enormous amount of literature about these non-caloric sweeteners changing the gut microbiome. So one way that they cause diabetes is because they change the gut microbiota. And in some cases, they actually can make us get more calories, more energy from our food. And they also contribute to obesity that way. So extremely important. Oh, there was one thing I wanted to show that, in this article, it actually called for, a whole reassessment of the non-caloric sweetener usage as in the U.S. as a whole. But that still hasn't been addressed. So like everything else, I always have my own approach. And I think it's important that just like when you're going to build a house, you need a really strong and sturdy foundation. For us, for my approach to insulin resistance and diabetes, it's food, right? It's wholesome, colorful, fresh, organic, and processed, high fiber, as I mentioned, fermented, that includes some nuts and seeds, and high in omega-3 fatty acids. We're going to try and assess but modify the gut microbiota. Yes?
Well, you say decrease insulin stimulation. Fat is the one nutrient that doesn't stimulate insulin.
Well, exactly. So you want. That's why I said you want to have good amounts of fat. So you want to eat your avocado. You want to eat your omega-3 fatty acids, because not only does it not stimulate, it actually helps stabilize your insulin and your blood sugar. Right? So when you're eating, let's say that you're eating a higher amount of sugar, for example. Like I always tell my patients, if you're going to cheat smartly. Because we're all human beings and nobody's perfect, and eventually we're going to want to eat something that may not be good for our sugar levels. But when you do, let's say you're going to eat that flourless chocolate cake, right? Then have some good fat with it and have a good amount of protein and have your green leafy vegetables. Because fat can prolong the effect. It won't let your insulin go up as high, and it creates a more sort of depot effect. So you may go up a little over a longer period of time, but it won't spike as much. And then you want to look for those triggers and mediators, and particularly your antecedents and triggers, and try and modify them. And then you want to decrease your insulin stimulation. And all these I'll get to a little bit more in a little while. And then I put all my patients in an elimination diet. Not just removing gluten, but removing the most allergenic foods and then bringing them back so we get an idea. Because a lot of times you can have a reaction that's immune mediated. So you can do an allergy test and they may not have an allergy or a sensitivity, but they can have a non-immune reaction that is causing their insulin resistance. And then so we want to personalize that, and we want to talk about digestion and making sure that they're chewing 30 times. And then you have to talk about lifestyle and movement. And sometimes exercise is a dirty word, but if you talk about just moving and having patients do what they like to do. Like I always say, I don't like to exercise for the sake of exercising, but there are different movements that I like to do, and so that becomes my exercise. or the form of movement that I do. And sleep. Do you know that by sleeping 2 less hours a night, like from 8 hours to 6 hours, you can become temporarily insulin resistant? And if you do it persistently for a week, you're insulin resistant, period. That's going from 8 hours to 6 hours, so extremely important. And then we can supplement, but I think we should supplement only after you've fixed all those things. You looked at somebody's lifestyle, you looked at how they're sleeping, and you've implemented all the things I've just talked about in the diet. And then you have to really talk about what I call the mind-spirit connection, and that is, how do we react to stress? How can we buffer our stress reactions? Because stress is there, right? And it's everywhere. And we live in this multitask, get it done yesterday, hurry up world, and we can't always change our stressors, but we can change how we react to them. And there's a lot of different tools out there that we can use. So then I broke it down even further to 3 different things. And that is, number 1, to decrease insulin resistance is you try and decrease insulin stimulation. Fiber, talking about good fats versus bad fats, for example, and having your low glycemic load carb with your protein and your good fat at every meal. And then you're going to modify your gut microbiota. And I said you can do that with food first, particularly with fiber. And then we're going to increase our cellular responsiveness to insulin, or our insulin sensitivity, by some of the supplements that we can add to our diet. But even aside from supplements, I think it's extremely important that we look at other things that are non-pharmacological that help that. So things like probiotics and prebiotics, but also even herbs and spices, because all of those act to help insulin get inside the cell, to help insulin work better. So what am I talking about? Like cinnamon and green tea and, for example, turmeric. And for spices, things like basil and, what's that small little leaf? Cilantro. Cilantro works too, and parsley. But thyme is what I was thinking about. Extremely good at helping at the insulin receptor. And then there are many other things we can talk about in terms of your food. For example, what can we do in terms of caloric restriction? We have a few studies showing that even by restricting calories, you can also decrease your insulin resistance. And limiting the amount of sugar that you eat, right? 5%, even just of your total caloric intake, even just decreasing it from 5 to 10%, you can make a big difference. So sometimes it's baby steps. This is a slide that talks about the green tea and quercetin and some of the things I talked about, how they act in the same receptor that helps insulin get inside the cell. So sometimes you can even think of, for example, my patients often talk to me about, well, but don't I still have to take a prescription drug? I said, well, first of all, we have to look at how that prescription drug is working. What's the mechanism of action? Can we replicate that with a food or a supplement, right? And what does the literature say? For example, how many of you have heard of metformin? A very popular drug, right, for insulin resistance, type 2 diabetes. Do you know that there was a study called the Diabetes Prevention Trial where they took 3 groups of people? One, they gave them metformin. Another group, they gave them a diet and went home, and they were studying them. This multiple centers. It was almost 3,500 people, and then they were going to see them back periodically, and they were trying to compare the 3 groups. So the second group, they just gave them a diet and told them to go home and follow the diet. The third group, they gave them a diet, lifestyle interventions. They had them exercise 150 minutes a week, and they followed them every 2 weeks. Now, out of those 3 groups, who do you think did the best? But when I tell my average patient that, who do you think they say? The drug. Because they're so ingrained. That's what we hear on TV and radio and you name it, right? They think, oh no, the drug did better. Actually, that study was stopped early because there's a rule in which sort of when you're at the half point, then and you're analyzing the data, you have to offer that to the other groups. And they didn't want to do that because it would have cost too much. And it was kind of shoved under the rug. But I think that's a really powerful study because those who were on the lifestyle intervention did better. It was 31% versus 67% in reversal of diabetes or prediabetes. And this is a study that talked about how you can, within 24 hours of changing your diet, you can actually change your gut microbiota. And that was revolutionary because we'd always been told that no, that wasn't possible. And we know that you can. So by eating more fiber, more nuts and seeds, and you can actually change for the better your gut microbiota. And then this article on caloric restriction is pretty interesting because I don't know if you guys remember hearing in the news, but when they first started doing a lot of the bypasses for people who were overweight and diabetic, those who were diabetic, we started seeing reversal of the diabetes before people lost weight. Do you remember that? Those that had all the gastric bypass or the stomach stapling. And guess why that happened? It was because by doing the surgery, they were changing the gut microbiota, and that's why people lost weight. And that's why they stopped being diabetic, because in most cases, their diabetes would go away way before they lost the weight. So that was one of some of the first studies where they were talking about caloric restriction. And then what about just snacking? Well, sometimes people get hypoglycemic and they have to snack. But every time we snack or every time we eat, we're also increasing our toxins, right? We're creating more sort of an exposure to endotoxins. So it's just another thing to take into account. Because when you put all this together, you can actually make quite a few interventions. And then I'm always asked, so what's the best diet to be on? And it's the Mediterranean type diet. Not the Mediterranean diet where you're eating lots of pasta, but the one where you're having your polyphenols, so you're eating your olive oil and lots of green leafy vegetables, and you're eating fish, right? That type of Mediterranean diet. But we also have to personalize it to each person. And this is a study showing how, even two diabetics are not alike. And so you have to test and see what they're eating, because even though two type 2 diabetics may be eating the exact same food, their reaction may be a little bit different. And so you want to make sure that you're addressing it and you're individualizing it. And then I talked about how we can modify with food, but you can also add probiotics and prebiotics, just like antibiotics can also affect the gut microbiota. I always believe in increasing, prebiotics slowly, because those are mostly your fiber, and sometimes patients can't handle that very well. So those 35 grams of fiber that I talked about, sometimes you want to go really slowly. Now, there's quite a few probiotics, and I know I'm getting behind on time here, but there's quite a few probiotics out there. And I wanted to go through 4 of the ones that are best studied in insulin resistance and in changing the gut microbiota. And one is Lactobacillus reuteri. Lactobacillus reuteri has been around for a long time. It's even an infant formula. And there was a study in which they looked at, it was done in mice, they looked at Lactobacillus reuteri, adding it to these mice that were given fast food, for example. And even though they didn't change their diet, so they had several groups, and even though they didn't change their diet and they gave them the unhealthy diet, just by adding the Lactobacillus reuteri, you saw a reversal of the insulin resistance. So this doesn't mean that we don't do everything else, but this means that, like in my non-compliant patients, I can add a probiotic and actually make a difference. And sometimes that's the trigger. That's the thing that patients need to see that they can make a difference, and then a lot of times they're more compliant. The other is Lactobacillus gasseri BNR17. Also same thing, very well studied and showing that it can actually reverse and prevent insulin resistance. And the third is Lactobacillus casei. And you can actually get these 3 in one product. My favorite one, unfortunately, is a product that had those 3 is recently taken off the market. But you can get it in Hyperbiotics 15, which has all 3 in it. I personally like introducing one at a time because you can have a reaction, and that way you know what you were reacting to. In other words, you may have an adverse reaction. The 4th one is VSL number 3. Now, VSL number 3 is also a prescription. You can get VSL number 3 double strength. And so it's usually it's kept in the pharmacy, so you have to ask the pharmacist, but you can get it without a prescription, just not the double strength. And what about fermented foods? I talked about them before, but not in a lot of detail. Now, when it comes to fermented foods, we have to look at what type of bacterium is being used to ferment it, and I think that's extremely important. And most of the literature that supports it being used, particularly in insulin-resistant patients or diabetes, is Lactobacillus plantarum. because Lactobacillus plantarum also helps digest oxalates and histamine. So it's the one that I feel really comfortable using. You can get a fermented product that may have a lot of wild type bacteria that are being used, and you may not have a reaction, but I prefer to use Lactobacillus plantarum because there's lots of literature on it. And you can get, for example, there's a starter from Body Ecology that has both a kefir starter and a culture starter. So the culture starter can be used to culture vegetables or to make yogurt, whereas their kefir starter is to make kefir. And they're predominantly Lactobacillus plantarum is what's being used. I know the person who developed it, which was Donna Gates. She's worked for over 35 years to develop that product. Now remember that prebiotics are your fibers, and so when you start your fiber, sometimes patients can develop a little bit more gas or a bloating, so you start low and you go slow to get to that 35 grams like I talked about. And do you know that there's actually studies now on using fecal transplants to change the gut microbiota? Now, we don't have literature yet on diabetes or insulin resistance. In the United States, it's approved for Clostridium difficile. But in other countries, it's being used for autoimmune disease, and I know someone who did it for diabetes. This is that study that I had talked about earlier. And then also talking a little bit about, I know I'm out of time, but about glycemic load. So that when you look at foods, you want to look at what type of glycemic response. And we've heard quite a bit about glycemic index, but glycemic load is a little bit better because it looks at both the quantity and the quantity of the sugar or the carbohydrate in the food. And then exercise, I already mentioned, but extremely, extremely important, or movement, rather. And sometimes we have to be realistic with ourselves as well as with our friends or with our patients because, I still find that most of my patients, when we're talking about type 2 diabetes, they think that the outcome is inevitable, right? That there's just not much that they can do. And there is so much they can do. Or they're not really willing to look at the downstream effects if they don't change their lifestyle. And they think it's left to chance. It is not. A non-compliant diabetic, within 5 years, is going to have a stroke or a heart attack or go into kidney failure. And those things are completely preventable. I was just talking to someone else about the book by Dr. Richard Bernstein. Anybody of you have heard of him? I wish I had been taught this in medical school. So Richard Bernstein was a engineer, and his wife was a researcher, and she was involved in developing the first glucometer. He was a diabetic that was about to go on dialysis, and he was very unhappy about that. So one day, she brought one of the glucometers home. They were doing the beta testing to test his sugar because that wasn't available. He got so excited that at age 54, he quit his job, went to medical school, became an endocrinologist, reversed his diabetes, reversed his kidney disease first, and then wrote 2 books. And one of his books is called The Diabetes Cure, or no, The Diabetes Solution. And he did it all with diet. And it was all by monitoring his carbs. Now that is powerful. But I found that on my own. I just stumbled upon it. And things like that, that gives patients hope. And it really teaches us just how important your habits and your diet can be. And then sleep I already had talked about, but that can be the single trigger that causes someone to be insulin resistant. So extremely important to look at that. Now, these are the list of my favorite supplements. There's others out there. So chromium, alpha-lipoic acid, coenzyme Q10, vitamin D I already mentioned, magnesium, and omega-3 fatty acids, but you also have your vanadium and your antioxidants. And selective kinase response modulators, or SCRMs, are omega-3 as an example, but they're also what's found in herbs and spices that help the insulin get inside the cell. The next few slides are more just references talking about, for example, the amount of alpha-lipoic acid that has been studied, as well as your coenzyme Q10. By the way, with respect to coenzyme Q10, when you look at the reference ranges from the lab, you don't want to look at those when you're taking CoQ10. Or you want to look at those, but you don't want to just look and see if your number is high or low, because Dr. Sinatra, who's actually done most of the research on CoQ10, now says you want to get your level as high as you can. So don't, if your doctor says, oh, it's too high, look at the lab yourself, and look at the reference ranges. And he says you want to be 3 or higher, even though the reference ranges may only go up to 1.5. And then vitamin D, you want your level at least around 50. And then your magnesium. Now, magnesium, as long as you have normal kidney function, we really should be taking it to bowel tolerance, to how much you can take without having a loose bowel. Because the only really good test for magnesium is an intracellular test, which is actually you have to take a buccal swab. You have to swab the inside of your mouth and send it off. And there is a lab who does that, and it's covered by most insurances, but doctors usually don't know about that. So in conclusion, the main thing I like to say is remember diet, number 1, 30 to 35 grams of fiber, your 10 to 12 servings of your vegetables, and only 2 servings of fruit, and the low glycemic load. Remember to think happy thoughts and move. Just whatever you can, get your body to move. 150 minutes a week is what's been studied. I say any movement is important. And I am going to do a sort of a Change Your Life or Save Your Life series in my blog. So if you'd like my newsletter, I left a sign-up sheet for it. And thank you so much for your attention. I can take a few questions. I know I'm a little bit over, but I'll just take a few. Yes?
Could you please?
How much chia every day? Oh, I use 2 tablespoons if you can, because there are about 6 grams of fiber per teaspoon, so that's how I try and get the 35 in.
You say hemp hearts too?
Pardon?
Hemp hearts?
Yeah, it's also very high in fiber. So hemp hearts was the other question.
What's your food reintroduction protocol?
Oh, so when you've eliminated food for 3 to 4 weeks, then I have them reintroduce one at a time. You eat one food, whatever that one is. Like I usually do the one that I think is least allergenic, have them eat it twice in the same day, wait 2 to 3 days without eating, and then monitor their responses. And I give them a handout, sort of what they're looking for.
Is that list on your site?
It's on the IFM website. I don't think it's on my website because it is an IFM sort of copyrighted. But if you go to the IFM website, it's there. And it's under the toolkit. And it's the delayed food reintroduction plan.
So, do you not like xylitol?
The problem, it's not so much that I don't like xylitol, it's that a lot of people can't tolerate xylitol, so that they get a lot of bloating and gas after eating it, particularly those that have a problem with FODMAPs. But there is now a product, a fermented xylitol, that I actually like, and it's called Lakanto. And I forgot to mention that, because that doesn't have Lakanto, Lakanto. Thanks for bringing that up, because I'd forgotten to mention it.
What's your favorite cookbook? Also, what do you feel about yogurt, non-fat, no sugar? And what do you feel about coconut milk?
So I have several favorite cookbooks. So probably the one that I'm using the most right now, because I've been on this grain-free diet, except I had rice today, is Against All Grains by Danielle Walker. She's got a great book. It's heavy in the nuts, but for a while I was doing modified ketogenic diet, and that book really helped me. Because I always believe if I'm going to put a patient on a diet, I better have tried it myself and know what it's like. Coconut milk, because your question was about coconut milk. Coconut milk is great, but you have to be careful what is in it, because most coconut milks are really, coconut milk doesn't exist, so it's when they scoop out the inside of the coconut after taking out the coconut water, and then they add water to it, and many times there's preservatives. So what I like is creamed coconut. There's an organic creamed coconut, which basically they just scoop everything out of the coconut and they package it in a non-plastic wrap. And then I reconstitute that with water, usually 1 package to a liter of water, and that's what I use to make yogurt. And I like making my own yogurt. So because I think when it comes to yogurt, like the ones that you buy over the counter, when you look on the label, there's a lot of additives to it. It's a little bit more time consuming, but when you make your own, you know exactly what you're putting in. And you can make it with any nut milk that you like, or any milk, whether it's dairy or not, that you use.
Would it be appropriate to mention a good source which I talked to you about before, of Lactobacillus reuteri and plantarum.
So the plantarum I use from body
I just
ecology.
wanted to mention that,
Yeah.
that source. Okay. Lifeway kefir, which is also a house brand of Trader Joe's, has both of those bacteria in them. Lactobacillus reuteri, which you mentioned favorably, and Lactobacillus plantarum. Trader Joe's, plain or whatever, blueberry if you wish, which has sugar in it. Those kefirs from Trader Joe's have those two probiotics in them. Just
Thank
wanted
you.
to mention
Yeah,
that.
I forgot to mention that.
Thank you.
Hello? Can Lyme disease affect insulin?
Yes, because it is one of the things that could have been the trigger, right? So it could be, remember I said one of the triggers can be an infection, and it can be an occult infection. So that could have been the trigger. But I often also see the opposite, that when you have insulin resistance, you're more immunosuppressed, you're more inflamed, and so even though you may have had a dormant Lyme infection, it may become more activated that way. So I see it both.
Do you do heavy metal detox, like especially mercury from your amalgam nodules?
Yes, I do. I actually used to do a lot of chelation. I don't do that anymore because IV chelation, right, intravenous, because I find that with food and supplements you can get that chelation. I mean, for example, with mercury, you can add cilantro to your foods and making sure you're getting plenty of vitamin C, so you're helping some of the excretion to the kidney and not causing more damage. But I find that with food it takes a little longer, but you can also chelate. When you have amalgams, it's hard because you always have to make the decision, are you going to remove the amalgams, which is much easier? But sometimes patients are pretty sick and you don't even want to remove them. You want to try and do a little bit of chelation and see how they respond, but always starting with food. And then there's other supplements you can add. Chlorella, for example, being one that you can do.
I have a question. As far as testing for heavy metals, I came across and started using the Quicksilver Scientific tri-test, and have you used that, or what do you use as far as testing?
So I haven't used that test. I've actually heard, and you're probably the third person, which means I need to look at it because, you know, my rule of threes. But I do it in the red blood cell because it's part of a nutrition test that I do for all my patients that looks at amino acids, heavy metals in the red blood cell, as well as all your vitamins and minerals and antioxidants. Now, that test, when you're looking in the red blood cell, that's only representative of what happened to you in the last 90 to 120 days, because that's how long a red blood cell lives. So it doesn't give you total body load. It just gives you the ongoing amount sort of that you're exposed to. But when I'm trying to figure out the total body load, I use the urine, the standard, sort of it's our gold standard, which is you can either give somebody something that will bring out the heavy metals, and then you collect the urine, or if I'm concerned about making somebody worse, I'll just do it in a baseline. So I may just collect 24-hour urine and then look at the heavy metals in that and maybe challenge them later just to get an idea of how much they have. But I'll have to look at that.
I would really encourage it because I start with the tri-test, the Quicksilver Scientific tri-test. What you're doing is you're getting actually the hair, urine, and blood, and you're looking at the different species of mercury. So I find it. I've just in the last 3 months started using that, and I'm really finding it's very good. There's also a lot of information and videos and scientific explanation and references on their website too.
Well, thank you.
So, okay, the last question. I think because of time for our next speaker, if people don't mind, I think maybe we could have this the final question for this lecture, and then we'll go, if everybody doesn't mind, just go right, or maybe take like 3 minutes, just a restroom break, and come right back, and then we'll start with our next speaker, okay?
Could you elaborate on snacking and toxin exposure?
So basically, it's that every time that we eat, right, we have a little bit of endotoxemia. So in other words, you have a little bit more toxic load to your body. And that's why there's the literature saying maybe you don't want to eat 8 meals a day, maybe you want to try and limit 3 to 5 meals. I think you have to take that information and tailor it to the patient. So for example, I know that if I don't have my snacks, I can get hypoglycemic. So I also know that every time I eat, I am increasing sort of my toxin load. So what I do is I try to add more antioxidants when I eat, whether I take extra supplements or I take foods that are high in antioxidants. Just because we know that we don't want to try and increase somebody's toxic load when you're trying to detoxify them. So you just take that information into account and increase as much as you can your antioxidants. I have yet to get somebody in trouble by increasing their antioxidants, so I always figure that that's a safe thing to do, starting with food first.
Thank you. Great presentation.